Thank you very much, David. I'm going to ask you and Paul to turn on your cameras, and thank you. I was going to ask beforehand, how long have you been back? I apologize. I'm getting old and forgetful.
Since 1st of October.
Okay, so about 2 months. Okay, good. Okay, Paul, I don't know if you want to start with questions or again, include your questions in the chat, but please.
Sure, let me kick in. Really enjoyed your presentation. Challenging population, and often the patients who have a hyperdynamic myocardium, as they age, this can change and they can switch into a reduced ejection fraction. How do you monitor these therapies and these patients?
Monitoring the therapies such as beta blocker and calcium blockers.
Yes.
Well, I mean, almost all patients with hypertrophic cardiomyopathy and with therapy should be followed by a cardiologist, and follow up with echocardiography is essentially the only therapy and the only approach that I think is reasonable. I guess the main question is how frequently you should follow these patients, and I think the guideline recommendations are between 1 to 2 years, depending on how severe their phenotype is. So yeah.
Good.
David, I'm going to just put a little editorial in here because it was this week I found out a patient called me. So those of you in the audience who have patients on disopyramide, and in 2012 or 2013, there was a threat of bringing the product off the market. There's no threat of bringing the product off the market, but like your shingles for your cottage, there's a supply chain issue, and there's none available at the present time. And so if you have patients who are on this drug, and I have a few, I did reach out to the hypertrophic cardiomyopathy clinic in Toronto, and they are advising that there's a word on the street that there should be some available in mid-December, but to advise reducing the dosing frequency to try and extend it out. David, with your experience back in the UK, have you come across patients who've been treated with mavacamten? Have you had any in clinical trials where it's been used? And this really seems to me, when I heard a fair bit about it, the CCS, like it has the potential to make a substantial difference in those patients. Those improvements in Kansas City questionnaire scores, scores are very high. Do you have a sense as to where it's going to fit, or is it not clear? And I know this is from reading and perhaps not from any personal experience. And I know you're more on the electrical side and the inherited side, but I'm just curious.
Yeah, I did take the opportunity to speak to Dr. Ryder about this prior to this discussion, because I had exactly the same question. And I think he made the very valid point that one of the major factors is going to be to do with accessibility and cost, whereas disopyramide is not expensive. Mavacamten may have a very substantial cost attached to it, and therefore I would think that that's going to be an important factor in where it comes in the hierarchy of things. I don't have any experience of looking after patients who've been on mavacamten, but I did when I was in London, frequently do clinics with the hypertrophic cardiomyopathy team there. And one of the things that we found quite frequently was that patients often did not tolerate disopyramide particularly well, and often up titration to a dose that was effective was really limited by side effects. So I think it's potentially quite promising as an alternative for those patients who can't have disopyramide up titrated to an effective dose. So I would imagine it's going to come after disopyramide, and particularly in those who maybe have too many comorbidities for a surgical intervention to be considered, or in centers where there isn't a wealth of experience in septal reduction therapy surgeries.
Are we still doing alcohol ablation with these patients? Is that still a treatment option?
Do you want me to take that, David? Here?
Yeah, please.
Yeah. So early on, John Howlett and then Mike Love did a fair number here, and there's wide ranging approaches, with some centers very much pro alcohol septal ablation and others very much pro surgical reduction. The pacemaker rate is significantly higher with alcohol septal ablation. We have no one here who has done one, to my knowledge. Assam is not online. He's done most everything, so he may have done it while he was in Saudi. And so and Toronto is very much a surgery-focused center, from my experience in interacting with them. There are selective patients who are poor surgical candidates where it could be considered. We don't have an established hypertrophic cardiomyopathy clinic, so everybody sees a grab bag. I have seen a fair number, probably had 10 or 20 patients operated on over the 20 years I've been here. And I worked closely with John Sullivan originally and Jeremy Wood on a direct, every patient is seen beforehand. We review the data beforehand. If I think it's, I tell all the patients, the guidelines say you should go to a high volume center. We're not a high volume center. Many of the patients, as you know, will just say, I'm not going. Other ones, they just say, I'm not going, or they're saying, they come in saying, you're going to send me to Toronto or wherever it is they decided they want to go. So, so we have had, I think, very good outcomes with the patients. I can think almost all of them have improved, and the improvement post septal reduction surgery in patients who have significant outflow tract obstruction, it's like operating on severe aortic stenosis. It's that gratifying. Young patients in their 40s go from severely limited to normal. Old patients in their 70s go from severely limited to normal. It really is, in the right patient, a fantastic operation. I'm going to stop on that. So that's it. So we have no septal alcohol septal ablation. I don't know what other cardiologists, I'm not the only person who sees these patients, have done in terms of their referral pattern, but I think it is somewhere you want to concentrate the expertise into one set of hands, is what the recommendations are, with perhaps an assistant who then becomes the replacement as they go along, right? Because not everyone works forever. Kim, so there's two questions here. This is more up your alley, I think, David. What do you use, the ESC score for sudden death risk? And then the role of septal thickness and MRI, I guess, in the sudden death risk assessment, is a question from Michelle Dastu in Moncton. So David, do you want to take that?
Yeah, sure. So I think that the trend has generally been, or the argument has generally been, that the ESC score has a risk of, to some extent, underestimating the risk of sudden death in some high risk patients, particularly in younger patients. And so I actually use a combination of both of those. So if they have any of the high risk markers specified in the US guidelines, in the North American guidelines, then I'll consider that, or someone with a high ESC score. And of course, yeah. So that I would effectively use both, and whichever one suggests the higher risk, I would take that as being more relevant.
There are a couple other comments here. I guess the question from Doug, what kind of physicians practice in the HCM clinic? And then a comment from Kim, we see many in the cardiomyopathy clinic. So they're not easy patients. So who were the members of the clinic that you worked with in London, David?
So the clinic was mainly run by Dr. Maiti Tome, who did work at the Heart Hospital and then moved to St. George's. And she saw the vast majority of the patients. They were mainly focused in her hands. And although there were a scattering of patients with less severe phenotypes were spread between the other inherited heart, the doctors specializing in inherited heart diseases, particularly cardiomyopathies. So that was Professor Sharma and Dr. Papadakis. So yes, but most of the expertise, in particularly in obstructive hypertrophic cardiomyopathy, were focused in that one individual who, since she had yeah, she had more experience and a better working relationship with the surgeons rather than yeah, that was because it is a small number of patients who will ultimately end up having surgery. And very often she would say that patients would be referred to her to be essentially managed with disopyramide, but with the expectation that they would not tolerate that. And that was considered to be kind of more of a stepping stone towards more advanced discussion. So yeah.
Yeah, I don't know if Kim or Doug want to turn on their cameras. Maybe we can do this because we're about to wrap up. But I've certainly had a number of patients who've done very well over a long period of time on disopyramide. And so it's not for everyone, and there are adverse effects. But you know, there's probably 5 or 7 patients that have been on a stable dose over a long period of time who feel better. There's a number where you try it and they just can't tolerate it, you know, for whatever reason. Yeah. I don't know, Kim or Doug, if you want to add anything about that discussion. And I'm happy if you guys want to take these patients, by the way. So,
well, one of the reasons why we started this clinic was we had a patient who unfortunately passed away because of pulmonary hypertension related to their hypertrophic cardiomyopathy and diastolic dysfunction. So we felt it was important that these patients be closely followed, that their pulmonary pressures be closely monitored, and if transplant becomes, or if there's symptoms or pulmonary hypertension become problematic, then transplant remains an option for these individuals, and they should be. We should try to catch every single one of them, or offer that at least as a potential therapy for every one of them.
okay, Kim.
And I would say that it often comes also in the differential diagnosis of someone has LVH. We know that something is abnormal, but I can't find what it is for the rest. So we do the rest of the investigations, the biopsy, or the weird stuff comes in those clinics. But effectively, many of them might have hypertrophic cardiomyopathy. And but effectively, when I trained in Toronto, Dr. Rakowski in their clinic, they used to, one of her staff in her transplant was also trained in HCM. And usually when the ejection fraction starts to begins with a 4, they would send those patients to the transplant clinic. So they would be monitored there, because some of them will have deterioration of their EF, but they will have much more symptoms compared to a dilated cardiomyopathy of an EF of 20%. And it will need transplantation often earlier, because they will develop end organ dysfunction that makes them non-transplant eligible. So of course, for a population of 75 years old, that's not the main focus, but for someone who's 40 years old, that becomes a tough decision sometimes. So it's easier if you see it coming before.
I'd like to thank our speakers. I'd like to thank those of you who've come on and participated. I see there's a comment from Osama that we'd be happy to start a clinic. I suspect he's done septal ablations as well, because he has a broad experience. Reach out and say thank you. Touch the industry partners for their support. You will get an email for electronic evaluation, and then you will get your certificate of completion. It is getting time for the completion times. I'd like to thank everyone. I do think we're still in the process of determining, but I hope in May we will get together face to face. With that, I'd very much like to thank Paul, Kim, David, and Doug. Superb presentations, really very high quality. Thank you for the time and effort in putting them together, and we'll see you next time.